Good morning.
I know, I know. Look, I see it all over your face. It was past the midnight hour. I fell asleep and forgot. So when I woke
Hey,
up,
that's understandable.
I said, "Oh my God." So at 2 o'clock, I was scrambling, like, "Oh, let me figure it out." How you doing?
I'm okay. I don't know what is going on, but I might have to, I'm gonna have to try from another computer because StreamYard is not picking up my camera again this week.
We see you. We see you.
But no, that's because I'm on my phone. I'm using my phone camera.
Oh, oh no.
I don't know what's
Yeah, we got
going
to
on.
figure out what's happening or
Yeah.
what's the connection, or maybe something is off. What? We don't like that because we like seeing
Mm-mm.
your face. But I saw the look. I looked. I was like, uh-oh. Maybe they done bumped something out because of all the new tools and all the new stuff that they give us. I don't know. I don't know. To be
Me
candid,
either.
be like that.
Hmm.
Okay, all right. Well, let's get this party started. Welcome, welcome to our Saturday morning tea. Here we brew up the hottest topics in healthcare. We discuss health information, news, education, StreamYard mishaps, people who fall asleep and don't do their work, and seeing lovely faces on camera or on phone cameras. Yes. We also discuss education, certification tips, and entrepreneurship, really the revenue cycle at large. And as you come in, don't forget to hit the thumbs up or like button. I'm Clarice Warner, the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance and education. Now, let me ask you, do you know what it takes to be a certified marketable medical coder? Do you? For real, for real? Well, before I introduce my co host, let me share with you information on a free, yes, free email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. I need to play the long version or something. I never get enough of that. I love that. I don't even know where I found that little tune, but I love it. All right, all right. If you are interested in getting more information about the 5 steps to become a certified marketable medical coder, check the video description for the link. Joining me today is my partner in success, my co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is, excuse me, my name is Jesse. I live in Philadelphia. I've been in healthcare for a long time, and I left the bedside in 2014 and switched over and transitioned into risk adjustment coding during the pandemic. In 2020, I created a company, the Coding Nurse LLC, where I help nurses and other people in healthcare with a clinical background transition into the wonderful world of HIM.
And how is that going?
It's coming along.
Okay, okay.
And as you know, you were talking about marketable. Look, today's um, podcast is going to be all about marketable in the and it's serious.
It's serious. It's it's serious. It's serious. But before we jump in, let me remind you that you can join in and add to the conversation. So don't be shy. Don't be shy. Your opinion matters and is welcomed here. So, friends, please use the chat. This is gonna drive me crazy. My alarm thing is going off. I don't know why. But anyway, please use, I don't know if y'all can hear it, but it's driving me crazy. Please use the chat. If you have a question, please type Q first so we know it is a question for us and we don't miss it. All right, let's see who we got in the room today. Let's see. Good morning. Good morning. Good morning, Natasha. Good morning, Carmen. Good morning. Good morning. Good morning. Welcome. Welcome. Okay. Let's see. We're doing all the things today and all the things we are doing. All right. So let's get into, well, before we get into our topic, I think it's time for us to get into our church announcements. But let me just tell you, today we're going to talk about AHIMA's plan and what coders must know. I guess, well, taking that even further, let's make sure we're keeping folks accountable and all of those things. I think that's an important takeaway from our conversation today as well. All right, let me put my music on. My music. Hey. All right. So, last week we talked a little bit about towards the end, I guess to say. Oh my goodness. So I picked up my phone. I was looking for something. We have a little slight scandal going on here in Cincinnati. It's crazy because it's all over Facebook. But let me just digress. Anyway, we'll talk about it more in the meeting after the meeting. But anyway, oh, child. We talked about the AHIMA and their meeting that they had, town hall meeting that they had this past week. Did anybody go? Why can't I get her off here?
Okay. I did.
Did you go? Mm-hmm. I knew you would. So today's announcement, just wanted to see, do a check. You can post in the comments if you actually attended the town hall meeting and what some of your thoughts were. We will definitely dig more into the town hall and the meeting after the meeting. But Mr. Jesse, did you have anything you wanted to talk about specifically related to the town hall?
I don't know.
They stayed on time. Look, they stayed on time. It was punctual.
I don't know. I don't know. I just think that overall they have a messaging problem. That and that really just sums it up. But it's a lot. It's deeper than that. Like they just don't know. I just they always fall short a little. I'm just not understanding.
Even some of the things we're going to talk about today. While I do agree and understand, I got an eyebrow raise. How about that? I got a little eyebrow. Like, is that really it? Is that? Yeah. So it's a lot. It
is.
Yeah. So if you joined it, let us know your thoughts. What did you think about? There was something, because when the questions came at the end, that's when I said I leaned in real hard, like, because they was coming, and folks were not playing any games here, and I felt like felt like they did an okay job in trying to address them, but I also felt like for some reason they seem to be a little caught off guard on some things, and I don't understand why. Because this is, to me, the message or the questions or the things that were discussed were not new. And maybe they just don't, as I say all the time, maybe they just haven't read the room. Maybe they just see their room and haven't read the broader room. Maybe that's part of the issue. Because if you don't know the broader landscape, it's gonna be hard to play the right music. That's why I tell the DJs all the time. You got to read the room. If nobody is dancing and you just up here jamming, then this party is not for you.
But how can you be in leadership positions in a member organization and not know the issues your members are facing?
Or not know, but not really address. Like what is that? I don't know. I'm in my feelings. I'm in my feelings about the whole thing. But I wanted to make sure that you all were quite informed about some of the things that happened at the meeting. So that's part of our topic of discussion today. The other thing I had, as far as church announcements, and that's why I picked up my phone, because I'm looking for it. There is an RFI that was put out by CMS regarding, it's called the CRUSH Initiative. And I was looking for the acronym. I'm sorry. Didn't I say I wasn't on my job this week? It was a CRUSH acronym. And it's an initiative that is going deeper in finding fraud, waste, and abuse within healthcare. And I think there was a focus on durable medical equipment, but really healthcare in general. But the RFI was interesting to me because it's asking you to help them help us. They want, to get your insight or information on what you think, they should be looking at, and how they need to go about it. So I thought that was a different twist and interesting to me. But we'll talk more about that later. But the RFI thing was a little chuckle to me. Like, really, this is what we're doing now? Okay, all right. But that's all I had. Mr. Jesse, do you have any church announcements?
No.
Okay. All right. Well, let's get into the get down today. Gotta let my music go. All right. So today, as I mentioned, we are talking about AHIMA's plan and what coders must know. So let the tea spilling begin. Good morning, and welcome back to the Saturday Morning Tea, where we serve up the real talk our profession needs, especially today. I'm Clarice Warner, the girl with the pearls, with my partner in success, the coding nurse. And if you're new here, welcome. We meet every Saturday morning to demystify medical coding, billing, and everything that keeps healthcare revenue flowing, and talk about the things in healthcare that actually matter for your career, your compliance, and your paycheck. And to my returning friends, thank you for being here. So grab your favorite beverage. Again, no judgment on what that may be at 9:14 a.m. on a Saturday morning, and settle in. So what we are talking about today is important, not scary, but important. And there is a very big difference. Good morning, Roxanne. I'm reading some of the comments before. It was interesting, better than last year. The comments were off this time. Okay. All right. So today we are talking about a document that every single medical coder, health information professional, and healthcare leader should have on their radar. We're talking about AHIMA, and AHIMA stands for the American Health Information Management Association. We're talking about their official 2024 through 2027 strategic plan. Now, this was a document that was brought to us, hopefully not necessarily introduced to us, but brought to us at the town hall meeting just this past week. Mhm. Okay. Now, I want to break it down for you in a way that's warm, real, and as always, actionable. Because it could all be so simple, but only if we are informed. Now, you might be thinking, Clarice, why should I care about an organizational strategic plan? That's for the executives. That's for the board members. That's not for me, the one assigning codes. And I hear you, I really do. But here's what I know after years in this field. The strategic plans of organizations like AHIMA are not just internal roadmaps. They are signals, they are warnings, and they could be invitations. And when your premier professional association opens a 4-year blueprint with language about an inflection point and calls out artificial intelligence, automation, and workforce transformation as core priorities, yeah, that is your professional alarm clock going off. And today we're going to answer it together. Mr. Jesse, I know you're going to jump in. Look, I see it all over your face. So jump in, however, whenever. Now, before we go any further, let me just take a moment to make sure we are all speaking the same language. This conversation is going to involve some alphabet soup, and I never want anyone in this T family left behind. So here are your key terms for today. We already talked about AHIMA, which is the American Health Information Management Association. It was founded in 1928, and it's one of our premier credentialing and advocacy bodies. HI is just health information. So this is the broader profession. It includes coders, managers, data analysts, and CDI specialists. HIM is health information management, and this is managing health data, the collection, the accuracy, the storage, the use. We have all heard this a gazillion times, but AI is artificial intelligence. It's the technology that performs human-like reasoning tasks already in your workplace. NLP is natural language processing, AI that reads clinical documentation and powers automated coding tools. CAC, computer assisted coding, and this is the software that suggests codes from clinical notes using NLP. SDOH, social determinants of health. These are non-medical factors affecting outcomes, and these are coded via our Z codes. D4BH, data for better health. This is AHIMA's initiative on the social determinants health data collection and health equity. CDI, clinical documentation integrity, ensures documentation supports accurate and complete coding. HCC, hierarchical condition category. Again, this is about risk adjustment coding, high in demand in Medicare Advantage, and some of our coder people who are looking for positions. DRG, diagnosis related groups. In 1983, Medicare payment model that first tied coding to reimbursement. CEU, if you have any credential, you are already familiar, continuing education unit, and these are credits required to maintain your professional credentials. DEI. Now, let me just, before I even say this, remember this strategic plan started in 2024 before some of our new government initiative changes, but this information is still listed in the strategic plan, so I'll call that out. Um, Namely, this is named specifically in their strategic priorities. OIG, again, the Office of Inspector General, is the federal body overseeing healthcare fraud. Their audit focus is your compliance radar. Now, you are equipped and you're ready. So let's talk about what AHIMA is actually telling us. To understand why AHIMA's 2024 to 2027 strategic plan matters so much right now, we need to zoom out for just a minute, I promise. This is not a history lecture, this is context, because context is what separates a reaction from a strategy. So, way back in the day, in 1928, the beginning, AHIMA was founded as the Association of Record Librarians of North America. Yes, record librarians. Our entire profession was built on one idea: organized, accurate health records lead to better care. Now, that idea has never changed. What has changed is everything around that. Fast forward 1983, the DRG revolution. The federal government introduced diagnosis related groups or DRGs as the payment mechanism for inpatient Medicare reimbursement. And so for the first time, medical coding was directly tied to hospital payment. Remember, medical coding was around and has been used for other things like statistics and such. But this was when it first became clear that this may be a way for us to tie what we do, how we do, to reimbursement. Overnight, the coder's role became financially critical. This was inflection point number one for our profession. In 1996, HIPAA changes everything. HIPAA, the Health Insurance Portability and Accountability Act, established the legal framework for protecting patient health information. Now, coders were not just billing professionals, they were compliance professionals. Privacy, security, and data stewardship became part of the job description. In 2009, high tech and the digital term, the Health Information Technology for Economic and Clinical Health Act, or the HITECH Act, incentivized healthcare providers to adopt electronic health records, or EHRs. This digitized the documentation that coders work from and opened the door to automated tools assessing that data. In 2015, ICD-10 implementation, United States transitioned from ICD-9 CM to ICD-10 CM and ICD-10 PCS. Our code set expanded from roughly 14,000 codes to over 70,000, and many predicted catastrophe. Coders adapted. We always do. Again, we always do. In 2024, the AI inflection, computer assisted coding tools entered mainstream healthcare, natural language processing advanced rapidly, and payers began using AI to adjudicate and audit claims. And now, as AHIMA's 2024 through 2027 strategic plan makes clear, the association is telling us directly the profession is at an inflection point. Not the first, but potentially the most significant. A published analysis from September 2025 by Timothy Powell, who's a CPA and CHCP, was also an author at the Rack Monitor, noted that the AI tipping point for medical coding could arrive as early as 2029 to 2032, and that 65% of hospital CFOs surveyed plan to reduce their coding staff by up to 50% by 2030. So let those numbers breathe for a minute. Those numbers are sobering, but they are not a death sentence. They are a direction. And we've talked about this over and over and over again. And knowing the direction means you can choose your path. The coders who will thrive are not the ones waiting to see what happens. They are the ones preparing right now, right now. And that is exactly what we are doing today. Let's talk a little bit about the AHIMA's 5 strategic objectives. All right. The 20 AHIMA's 2024-2025 strategic plan is organized around 5 strategic objectives. And I'm going to walk you through each one and tell you what AHIMA is saying, and then tell you what that means for you as a working medical coder or health information professional. Because these are not just corporate goals, they are professional weather forecasts, if you will. Inflection point number 1, or talking point 1, is the inflection point. This is build brand and increase influence. That's their first objective. AHIMA is reimagining its membership and value proposition. They want to attract early career professionals, senior leaders, and people working in a greater variety of settings. And T family, here is the part I want you to lean in on. AHIMA says right there in the opening of this document that the health information profession is at an inflection point. Those are their words, not mine. An inflection point is where a curve changes direction. In real life, it is the moment where what you have always done stops being enough. The moment where staying still becomes a form of falling behind. Again, we've been here before. DRGs in 83, HIPAA in 96, ICD 10 in 2015. And each time the professionals who prepared came out stronger. That is going to be true this time too. Again, it could all be so simple, but only if we pay attention. Objective two is elevate and broaden the profession. Now, this one is especially important for you. AHIMA is committed to performing gap analyses on continuing education and on the relevance of current certifications and micro credentials. We are asking, what do members not know yet that they need to know? That means the credential landscape is actively being evaluated. So your CCS or certified coding specialist, your RHIA, registered health information administrator, your CDIP, certified documentation integrity practitioner, those credentials may evolve and new ones will emerge. So here is my question back to you. Have you done your own gap analysis lately? Do you know what skills you have today versus what an AI augmented coder needs tomorrow? That distance between those two answers is your professional development to do list. And it could all be so simple to start. Just name the gap. I'm jumping to objective five now because it is the one I want every coder to hear clearly. Objective five, commit to innovation and performance excellence. AHIMA explicitly names artificial intelligence, advanced analytics, privacy, and data integrity as their innovation focus areas. They want AHIMA to be the global expert destination on these topics. What does that mean for you? It means coders who understand how AI tools work, who can audit and validate AI generated code assignments, who can apply clinical judgment where the algorithm cannot. Those are the coders this infrastructure is being built to support. AI is not coming for your job. AI is coming for the parts of your job that do not require your brain. The question is, what are you doing with the parts that do? Talking point four, let me bring in the D4BH initiative. And again, that's Data for Better Health. AHIMA is positioning itself as the national leader in social determinants of health data. They are working to drive federal policy that improves how social determinants of health data is collected, shared, and used. And here is where coders are absolutely central to this. SDOH data is the healthcare setting in the healthcare setting is primarily captured through ICD-10 CMZ codes. The Z55 through Z65 code range covers housing instability, food insecurity, education barriers, employment problems, and psychosocial stressors. When you assign a Z59.0 for homelessness or a Z59.4 for lack of adequate food, you are not just satisfying a billing requirement. You are populating the national data set that policymakers use to understand health inequity. You are the pipeline. If you are not yet confident in your Z code knowledge, that is your next priority. I have a resource for you. Check out the show notes. Communities of practice. Objective 3 and 4 cover financial stewardship and culture. AHIMA is restructuring for financial sustainability and targeting a 15% or better operating margin. They are also naming DEI, diversity, equity, and inclusion as a named strategic priority. Again, this was done in 2024. I don't know if that's still going to be the same. I don't know, but it's still in the documentation. And importantly, AHIMA is launching communities of practice, at least 3 grounded in real world experience. This is your invitation. A community of practice is not just a fancy term. It's a space where professionals learn from each other, share resources, and build credibility by contributing expertise. Do not wait for a formal invitation. Start showing up where your profession is being built. AHIMA is actively assessing whether current credentials or certifications and micro credentials reflect what employers actually need. That is a responsible and brave thing for an organization to admit. For you as a credential holder, this is not threatening, it's an opportunity. So stay active in your continuing education. Pursue specialty credentials in high demand areas and watch for new micro credentials because they are coming and early adopters always have an advantage point. And I have saved this one for last because it is the one that fills me with some hope. AHIMA wants to engage directly with healthcare consumers. Who are our healthcare consumers? They are the patients. This is an interesting twist to me. Those people whose records we manage, whose codes we assign, and whose health stories we translate into data. If AHIMA grows public awareness of what health information professionals do, it elevates every coder, even or every HIM manager and every CDI specialist in the eyes of the public and healthcare leadership. This is good for the profession and good for your career brand. And speaking of career brand, this leads us right into our 3 pivot segments. But I'm going to pause right here. Mr. Jesse, do you have anything to add to this part of the conversation? While I grab my tea.
I really I have so much to say, but I don't even know where to start. I'm just not. So just go ahead.
So I thought it was curious the reach for patient and um, growing public awareness of what health information professionals do. While that is important, they need to know. I'm curious as the thought behind how does that impact, particularly healthcare leadership, because they tie them together. Um, I, that was different for me. Okay, but let's talk about these pivots. So we've talked about the landscape, we've talked about the history, and we've talked about what AHIMA is prioritizing. Now let's talk about you. Yes, you. Because knowledge without action is just a very interesting conversation, and we are here for transformation. So here are the 3 pivots that I want every medical coder and HI professional to be actively making right now. Some of these we've talked about. I can't repeat them enough times. I want you to feel this in your spirit, feel this in your soul. Listen to what we are saying and how it can impact you going forward in this profession, because all of this stuff will eventually knock at your door. Here's the truth nobody is saying quietly anymore. AI tools are already assigning codes in many health systems. We know this. CAC has been in use for years. We know this. What is changing is the sophistication, the speed, and the breadth of deployment. The question is no longer whether AI will assist with coding. The question is, who is going to check its work? That person needs to be you, the coder who can review AI-generated assignments, who can identify errors the algorithm missed, who can apply clinical judgment to documentation the NLP tool misinterpreted, who can flag compliance concerns. That coder is indispensable. The machine cannot replace the person auditing the machine. Enroll in an AI in health course or a CDI certificate program. AHIMA, AAPC, and HC Pro, our cousins, are all offer relevant options. The vocabulary alone will open some doors. Volunteer for your organization's AI governance. Ask to be on the committee, the task force, or the review team evaluating CAC and AI coding tools. If your organization does not have one, advocate for one. Presence in those conversations is how coders stay central rather than peripheral. Build your audit practice intentionally. We've talked about this before. Pull 10 AI assisted claims per month, review them manually, document discrepancies, and track patterns. Again, this is not extra work. This is your evidence portfolio that demonstrates your value as a human quality checkpoint. Pivot number 2, going from generalist coder to data specialist. Remember AHIMA's D4BH initiative. Their workforce needs assessment, their investment in analytics, all of it points to the same direction. The healthcare industry does not just need people who can assign codes, it needs people who understand what those codes mean in the context of population health, quality metrics, and data driven decision making. The generalist coder who does a little of everything is increasingly vulnerable to automation. The specialty expert who knows one domain deeply, oncology, HCC risk adjustment, social determinants of health, behavioral health, is a subject matter expert. Subject matter experts are not interchangeable, and interchangeable is the thing we need not to be. Step 1, master your SDOHZ codes right now. Pull the ICD-10 CM Z55 through Z65 code range and study it. While you're studying it, make sure you're studying the guidelines that are associated with it. Know the categories, know the common codes, know when they apply and what documentation you need. Become the person in your department who answers the SDOH coding questions. Check your Patreon member portal for reference guides. We got some stuff there for you if you are a member of our Patreon. Step 2, pursue a specialty credential or micro-credential. The AAPC's Certified Risk Adjustment Coder, or CRC, is one of the highest value specialty credentials in the market right now. Oncology coding, CDI, and HIM data analytics are also strong options. Mr. Jesse could tell you over and over and over again how strong these are. Pick one and go deep. Develop your data literacy. You do not need to become a data scientist, but you do need to read a dashboard, interpret a denial report, understand what your codes contribute to quality metrics. Start with a free Power BI or Tableau beginner course. LinkedIn Learning has excellent options because it could all be so simple. Just start with one tutorial. Pivot 3, from isolated worker to visible professional brand. AHIMA wants to increase visibility of the HI profession with employers, policymakers, and even patients. But institutional visibility has to be matched with individual professional visibility. If AHIMA is building awareness of what HI professionals do, you need to make sure people can find you when they go looking. And I know many of us went into this field because we love the work, not the spotlight. But here's the reframe. Visibility is not vanity. Visibility is professional survival. In a world where automation is doing more of the transactional work, the professionals who are seen, who are known, who contribute, who are connected are the ones who get called first when opportunities arise. Refresh your LinkedIn profile this week, not next month, this week. Update your headline to reflect your specialty. Add your credentials. Write a short summary in your own voice that answers the question, what do I bring to healthcare that a machine cannot? And then post something once a month at a minimum. Join a community of practice and contribute. When AHIMA launches their communities of practice, the refresh, be one of the first to join. And do not just lurk. Share a real world experience and offer a resource. Ask a question that others think. It could all be so simple if you just show up. Attend one professional event this year, in person, virtual, a local chapter meeting, a national conference. It does not matter which one, just attend. Relationships and visibility are career infrastructure. They are not luxuries. They are the things that get you referred, recommended, and remembered when it matters most. All right, T family. I know I love this part. This is where we slow down and actually sit with what we have been learning. I'm going to ask you 5 questions and I want you to answer honestly, not for me, for you. Okay? For you. And if you're watching on YouTube, LinkedIn, or Facebook, drop your answers in the comments. If you're listening on our podcast, write them down. If you are a Patreon member, bring them to our meeting after the meeting discussion, because we got a lot to talk about. Question 1. AHIMA says the health information profession is at an inflection point. Where do you personally feel that shift in your day-to-day work? Are you seeing changes in your coding environment, your workflow, or your team structure? Question 2. If AHIMA conducted a gap analysis of your continuing education right now, what skills do you think would show up as missing? And are you already working to close that gap? Question number 3, as AI takes on more routine coding tasks, what uniquely human skills do you believe will protect your professional seat at the table? And are you actively developing those skills? We talked about this last week, skills versus credentials. That's a whole other conversation. Question number 4. AHIMA is prioritizing social determinants of health data and Z code usage. How confident are you in your Z code assignments? And does your organization consistently capture SDLH data? And number 5, AHIMA wants to engage directly with patients. How does your role as a coder connect to the patient experience? Have you ever thought about your work from the patient's point of view? All right, take your time with these questions. They do matter. They do. Okay. Mr. Jesse, did you find something? Besides the look of disgust that's on your face right now.
It all sounds nice, but it just sounds like it's just for me. I would just like a little straight talk for once. Like I mean, it's because it's like they're talking loud, but they're saying nothing. Because what the main takeaway from the town hall that I took away was that people are spending money going to these AHIMA programs. They can't find no damn jobs. And AHIMA has no solution for that. And you can do all the if you can do if you can't if none of this results in a bi-weekly direct deposit, what is it for?
But is AHIMA alone in that though?
But it doesn't matter because
That's what I'm saying. I don't think they're alone in that. I don't think they're alone in that at all.
Well, but we're not talking about anybody else right now. We're talking about a membership organization that's not addressing the fact that their members can't get jobs.
But I think you're right. You're right. But I don't think they're alone in that. I think a lot of membership organizations, or I think it's the same thing. Now let's talk specifically coding. It's the same thing. You got people going to AAPC's conferences and their meetings, and it's the same thing. Their people can't get jobs either.
But
it's a problem across the board. I just think it's a problem across the board.
But it doesn't matter. I mean, but
and I'm a member of both, so I see both. Right. It's a problem across the board.
But it doesn't matter whether it's across the board. The bottom line is AHIMA can't address the issue for the people who are in their programs and who are members of that organization. They have
And
to
other
answer that for
organizations
their
are having the
members.
same problem. That's
Right.
all I'm saying. I
Okay.
think they're all having the same problem.
Okay. But they all,
But somebody
because
got to
they,
fix it at some point.
exactly, that's what it all comes
That's what
down
it
to.
boils down to. Somebody
And
got to
they're
fix
not. They're not.
it.
They're
Somebody got
not.
to fix it. Somebody got to fix it in all of them. And maybe that's a conversation. Maybe all of these membership organizations need to get together and figure out and have a conversation. What are you doing? What are you doing? What are you doing? How can we help the people that are helping us or building us or keeping us somewhat afloat? I don't know. I don't know the answer to. But I think it's something that is across the board. And it looks bad for all of them. Not just one, all of them.
Well, I just think that AHIMA is especially egregious because the thing about because AAPC didn't buy an organization that had nothing to do with them or that we know had nothing to do with them. And what is the benefit? Like when they bought HC Pro, how does that benefit you and I as members?
It don't
How?
benefit me.
Exactly. So you spent this money doing what? Like what is it all for?
I think it was to broaden. Well, I take that back because HC Pro does have educational opportunities or educational things that AHIMA doesn't have. And so I think from that vantage point, I think part of them adopting some of the educational opportunities that HC Pro provides is a way that AHIMA may feel, and I'm not speaking for AHIMA, but I think that they feel that this may be something that they can offer their members. It broadens their reach. It broadens the offerings that they have, stuff that they can't do because they're a small organization of actual employee folks. They can't do all of that. So this was an opportunity to get to partner with a group that can, and supposedly, seemingly, most people think does it well. As far as other parts of HCC Pro, I don't know. I feel that, especially in the CDI realm, and I've said it a gazillion times, I feel like that is direct competition. I think that adds to a lot of the drama that is brewing between specifically CDI professionals who are coders versus the nurses. And I don't know if there was really a lot of thought put behind how do we manage that? Because while we're focusing more on the health information side of the world, and revenue cycle side of the world, touching a little bit in CDI, I think that's a keg that's gonna blow or that it's brewing right now. And at some point, I feel like AHIMA needs to address that. That's just me. But those are my 2 cents for the day.
Right. But that goes to my point. This is why they're talking loud and saying nothing because you have it all of that plan sounds nice, but how does that come how do you trickle that down into actionable steps for a member in your organization to move to the next step?
And
Meanwhile,
that
you go
go.
ahead.
I'm sorry. No. Go ahead. I didn't mean to cut you off.
No,
Go ahead.
go ahead, go ahead.
No, and that's why I said earlier, it's about accountability. So they brought this information. Can you actually say or pinpoint what the information has or has not done for you? Can you actually say, and I mean, I think that's where the accountability comes into play. Like, well, wait a minute, you said da 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 da. Your plan is XYZ. Make it make sense. Make it make sense.
Because so getting back to the whole actors, well, the HC Pro, because HC Pro does have other things that AHIMA doesn't, but there is specialty. I mean,
Mhm.
HC Pro is almost like AAPC because I have 2 home care credentials through HC Pro, and they also have actors. And I don't know what and they because under home care comes hospice. I don't know what else HC Pro does, but I know those are 2 things that they do. And when it comes to, so they bought HC Pro like 2 years ago, but there's still no clear answer from AHIMA or HC Pro about the CDIP versus CCDS. And what I do know, being a being a nurse, is that Actis is never ever ever going to change how they do their CCDS, because how they view CDI, they divorce themselves completely from coding. It is strictly clinical, period. They don't care about all the other stuff that coders and HIM professionals care about. All they care about are those clinical indicators and querying. That's it. That's all. And they're not ever going to change, because out of all the time that I have worked and heard and received stuff from actors, they never ever talk about coding, and they never will. Excuse me. So I don't even know what is the point. So if you buy this organization and you are at your core, and they call it HIM, but they have a lot of, they teach coding, AHIMA. There, you're, whether you're RHIA, RHIT, or a coder, you are exposed to coding. That's how you get into all the other specialties, through AHIMA, in my opinion. But I don't know how that's going to work. And they, in the interim, the members are losing out, because actors people are not complaining, because they already, their pathway is already in the bag. They take nurses who don't know nothing and train them. They have pathways set up. AHIMA doesn't have any pathways set up for their people. That's how you become marketable. This is why you have people talking about, I got my RHI, I got my RHIT last year, and I still don't have a job. And people at Actis ain't saying that, because they have a network. So
let me ask you this. So I know when CDI departments or things came in about, there were clear lanes that were supposedly developed to make sure that these CDI departments were successful and effective. Though you were supposed to have like your physician advisor, who would supposed to be a bridge between the physicians and the other people who had been validating documentation, da 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 da. You also had your coder lane, and those were the people who were coders, who were to assist in doing the coding validation piece and understanding the guidance and guidelines related to the codes and how they were supposed to be extracted and done. You also had the clinical lane, which was where the clinical folks, like your nurses, I don't know if there are any other clinical people that are in CDI, but I'll just, for the sake of argument, your nurses, where they were supposed to be able to do those clinical validation pieces. And everybody, while in their own lane, were supposed to work together to make sure that the documentation was accurate and complete. At least that was my understanding of how all of this was supposed to work when it first came to be. Somewhere, somehow along the way, lines got crossed, lanes got crossed, traffic is crazy. Everybody felt like, or not felt like, they can do everybody else's job. And in some cases they can, which I think has caused this confusion. I'll just say confusion. And I say that because, to your point, you mentioned the nurses are not involved or care less about coding because that was never their lane. Their lane was to do this clinical validation piece for CDI. So they don't have, they're trying to understand, well, why are you coming over here, or why are you coming for me? I'm doing what I was told to do in this context. Whereas others may not be doing the same thing in the defined roles as it was supposed to be historically. I mean, I know times have changed, years have passed, things have morphed, but that may be one of the reasons why you don't hear the nurses saying anything, because they stuck and stayed in the lane that they were provided. And they're gonna 10 toes down, stand there and stay there and protect that lane. And not really want to know or care to know what's happening in anybody else's lane, I think.
I understand everything that you said, and how that has been allowed to work is because, well, the issue, my issue is, or the sticking point that I have is, if that is how we, because I don't know what things were like back in the day, but for right now, like a if CDI is supposed to function the way it's supposed to function, then CDI should not be allowed to establish a working DRG. And if there's going to be, and there should be no need for the coder to contact the CDI specialist and say we have a DRG mismatch if you are going to divorce yourself from coding and strictly focus on clinical. Because that causes a lot of backup and it delays a lot of claims.
No, but
So
that was supposed to be like the three-headed prong. So yes, you would still be part of CDI and still provide those DRG validation pieces, which was part of the coding piece, but everybody had their role. And I think, again, however it got blurred or mashed or whatever to what it is today is what is causing some of that confusion. I don't know. I
and
just
also part of the confusion is what people don't understand, like, because for me, I say it all the time, you cannot do CDI in the 21st century without knowing coding, period. You just cannot. And what happens is, a coder, when you have a CDI department, a coder cannot send a query. You have to contact the CDI to have them send a query. And you basically have to explain to this CDI why a query needs to be sent or why the clarification is needed. Because I'm telling you, I have sat in plenty of teams conversation, well, watch plenty of teams conversations where people are, well, I don't think that's necessary. But you don't, you're not a coder. And a lot of times you cannot have, you have to have certain documentation. And this is where policy comes in.
Mhm,
There's not enough policy for how to clinically validate these conditions. Oh,
mhm,
people say, oh, well, we use UHDDS. Okay, well, that doesn't mean much, because UHDDS is very broad.
mhm.
You need a specific policy to validate heart failure, acute, chronic, systolic, diastolic. You need criteria. So if you don't know the criteria, or you don't know that let's just say the provide one provider documented acute and another one documented chronic, but if the CDI is supposed to uh, evaluate all this information while the person is in the hospital, in theory, when it goes to the coding department, it's supposed to be perfect. Coding is supposed to be able to just do what they do and push send, and it goes out. There
Mm.
should not be a need for the back and forth and waiting, a week for a provider to respond to a query, and then you resubmit a claim. All of this is what's causing all the backlog and all of this congestion, because it doesn't work as designed, as at least today, because it can, because it's people are too sick, it's too many claims involved, and there's too many people who don't know enough. I think that if that's how they want to keep CDI, then they should just let the coding department send the queries. If you're going to just rely on, oh, it's just clinical, because sometimes you need a query to define, to determine, like, clinical has nothing to do with whether whether somebody's poisoning was intentional or accidental. You're just going to deal with the physical effects of this poisoning.
Mm-hmm.
But we know for coding, you need to know whether it was an
Mm-hmm.
adverse effect or whether it was intentional. That
Mm-hmm.
affects it.
Mm-hmm.
It affects everything. It affects the DRG mainly because it affects how things get coded. So if you're going to divorce yourself, then divorce yourself all the way.
Well, I think there also needs to be, to your point, as it relates to policies, and clear definitions. There just needs to be some clarity around what, and maybe that's part of the conversation as well, because even in the CDI conversations, there's confusion about what folks' roles really are and how things are operated. And you know, maybe that is part of it, really clearly defining what these CDI departments are supposed to look like and how are they supposed to operate and what those workflows are supposed to be. And whether it's historically what they were supposed to be or what they are today with, automation and all the things that are upon us, I think that needs to be a conversation as well. And maybe these groups coming together can kind of do just that and define it for those of you all that work in that space, because it seems to be a mess. A whole hot mess. And folks are talking about it every day. All right. Well, as we are coming to the close of today's conversation, I want to leave you with something more than information. I want to leave you with a moment of honest encouragement. Now, we talked about AHIMA's strategic plan and AI encoding and workforce transformation, all the pivots, and all of it can feel heavy and it can feel like a lot. And it feels like a lot to me. So I'm sure it feels like a lot to you. And I want you to know it is okay to feel that, because change is uncomfortable and uncertainty is uncomfortable, as we hear in these conversations. But you know what else is uncomfortable? Being caught off guard when you could have been prepared. So you are listening to us right now, which means you are not caught off guard. You are paying attention and you are in the room where the conversation is happening, and that matters. So here is exactly what I want you to do after this episode. One, you can go to our Patreon page and download your exclusive member resources. If you are a PRN Hot Tea Sipper member, grab the AHIMA at a glance summary and the SDOH code quick reference guide. If you are an elite member, the career pivot assessment worksheet and the AI readiness self-audit checklist are waiting for you. These tools were built this exact moment. Well, were built for this exact moment in your career. So grab them. They are yours. They're for you. If you are not yet a Patreon member, today is the day. The link is in the show notes. I also have the QR code that is on the screen as well. Come join your community. We have a seat at the table for you, and we have been keeping it warm. Next, pick one pivot, just one of the pivots, and write down one action step you will take this week, not next month, this week, because progress is not accidental, it is intentional. And it could all be so simple if you just take the first step. Also, share this episode. If you have found value here today, send it to a colleague, a friend, a coder you care about, because we rise together in this family. No one gets left behind. Also, subscribe to the Saturday Morning Tea on your favorite podcast platform and follow Professional Reimbursement Network and the Coding Nurse on YouTube and social media. Every week, we bring you education that is actionable, accessible, and always in your corner. Mr. Jesse, do you have any closing thoughts? I know you're thinking of something. I see it on your face.
Just stay alert so you can stay marketable.
Okay. Remember, the machines are getting smarter. That is a fact. But here's another fact: you are smarter than the machines in the ways that matter most. You bring clinical judgment, you bring ethical reasoning, you bring context no algorithm can fully replicate. Your job is to make sure the world of healthcare knows that. And that starts with you believing it first. Okay? Okay. So join us next Saturday for another cup of tea and more coding insights. Until then, keep coding with confidence, keep learning with purpose, and keep shining your light. This is Clarice Warner, the girl with the pearls, reminding you that when we lead with knowledge and integrity, we can navigate any challenge. Remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care. Have a good weekend.